Morning, everybody. I This is a whistle-stop tour through cognitive rehab, not from a theoretical perspective, but what in terms of what you have to actually do on the ground. Um, I don't know how it is there now, but very often you'll find that we don't have the usual large team of psychologists, SOTs, and social work uh, to enable cognitive rehab to be actually carried out as it should be. And therefore, very often you'll find as a physiatrist that you have to do this single-handedly and often without the backup support of uh, of the bigger team. And so this presentation I'm doing is 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 based on that sort of approach. And as I said, it's a whistle-stop tour, so it's not going to be a lot of detail, but I'm more than happy to answer questions. So the first thing when you're doing cognitive rehab is to be sure that you are not being uh, um, dis distracted by other things. The first thing that can distract you and confuse you about whether this person has a cognitive impairment which needs cognitive rehab is delirium. The second thing, and you'll be surprised how often this catches you off guard, is whether they're wearing their spectacles or, do they have their hearing aids on or do they have their dentures on? And you can often mistake cognitive impairment um, for just an inability to see properly, hear properly, and speak properly. The third thing is that they may have had a previous event. So they may have already had a dysphagia from a previous stroke. They may have had previous difficulties from, well, I don't suppose you'll see very much multiple sclerosis, but there'll be other issues from the multiple sclerosis which impairs their ability to communicate. And the next commonest one that you can get very confused by is if you've got them just at the peak of their medications, if they've taken an anti-epileptic medication which is subtending their cognitive function or something else. And then the one which keeps on coming back to bite you in cognitive rehab is if they are fatigued. So if you catch them and they're fatigued, you will get nothing out. If you wait or choose a time where they're properly rested and are bright and preferably have a family member in the familiar surrounding quiet place, then you'll get better a better assessment. So that's to lay the ground for not being distracted or confused by things that could give you a falsely bad picture of what you're doing. So what are the things that you would expect cognitively? I'm putting cognitive fatigue as number one because very often you'll find that when you're providing cognitive rehab, you're actually going to be seeing the after effects of fatigue rather than the primary cognitive effects of a dysfunction. And you'll be surprised the number of times, of course, if you're actually providing cognitive rehab, it won't surprise you at all. But if you're starting off, you'll be very surprised at the number of times that cognitive fatigue is the biggest cause for impairment. And it's not technically a pure cognitive impairment, but it is the key to solving a lot of problems. The second one is cognitive visual dysfunction. And you'll find that people may not be able to see or communicate because they've got something like a Charles-Bonnet syndrome. The third is neuropsychiatric sequelae, and the most difficult bit of this is if they're depressed and don't want to engage or can't engage because of their mood, or if they think you're a intruder into their room whom they have to fight, then obviously the delusions and hallucinations of neuropsychiatric sequelae will get in your way. And finally, it's the neuropsychological Sequelae. So you know that when people acquire disability, they go through the same bereavement process that you would with death: denial, anger, bargaining, and acceptance, and this and sadness, obviously. But these sequelae can then actually present as cognitive impairments, and you have to be aware of that. They're not technically pure cognitive; they're neuropsychological, but they are impairments that can get in your way. The next thing to do, and this is about developing services, is to have a close link with your emergency department, because your mild traumatic brain injury cohort of patients will actually experience the most easily solvable cognitive difficulty. So they'll have some mild traumatic brain injury, may or may not present to emergency, and will have difficulties with episodic discontrol, sudden ups and downs of their emotion without proportionate cause. They may find it difficult to pay attention to things, and especially because they've got sound hypersensitivity. They may get slowed in their cognitive decision making, which won't present as a big, huge detectable problem, but they will notice it if they're working, or their employers may notice it. Have problems with fatigue and hypertension and headache, and they may be dizzy. And very often, if you don't explain to them that this is going to be there for the next few months, and explain to them that episodic discontrol needs to be dealt with, explain to them that their headache is not some tumor happening in their brain, they will actually land up with losing their jobs, very often losing family within a year. And so a little bit of education and reassurance goes a long way in a big benefit that you get, both for their health as well as for the wider community. So how do you sort of deal with the pure cognitive impairment, so to speak? The first thing is to look at it as issues with lobes. And there you can see that you can have distractibility and lack of drive with the left frontal, perseverations and hyperverbalization with the right, neglect with the right, I suppose, MCA territory part of the brain, inability to detect faces, right occipital, object agnosia, color anomia with the left occipital, and dyspraxia, dysphasias with the left, again, sort of left hemisphere. It's not always lobar, and just to be aware that there are, and we know this, obviously you'll know this from your understanding how the brain works and how we now understand the brain works. It's not purely lobar. There is a lot of crossover, a lot of quick messages going, and it's the millisecond delays between the messages that determine what cognitive impairment you have. And so you can have things which cross over. Classical example is emotional blindness, where people can't recognize emotions. And that's not down to just something in the occipital lobe. It's something which has a big, huge crossover. And you can see this is from a research paper describing what happens. It just goes back and forth across various parts of the various lobes on both sides. I haven't put the NICE guidelines in because they're not very specific, and obviously they're not based on much evidence. And this is a problem in cognitive rehab, that we still don't have good evidence to provide and to work on. You can also look at cognitive rehab from a perspective of which artery, and that's largely the same as what I just finished describing to you in the lobar areas, with a few exceptions. And I won't go through this in great detail. And if you obviously need to look at the details of this presentation, please do look at these slides. But basically, there is a pattern for right and left middle cerebral artery, strokes mainly, but any impairment which is vascular, largely aphasia on the left and neglect on the right. Similarly with the internal capsule, and you can get micrographia, abulia, and akinesia with the right side internal capsule, and that's something to be aware of. But again, patients don't read textbooks, and our brains, as I said, work on both sides. So you could have that with a bilateral anterior cerebral artery presentation as well. And then you have the precentral artery, which can give you neglect, and on the right, and aphasia and apraxia on the left. And you can see the picture developing. Apraxias and aphasias, or dyspraxias and dysphasias, tend to be the biggies that you can miss. And finally, not everything shows up on scans. So just having a normal scan, which you will have with mild traumatic brain injuries coming to A&E, they'll often get sent off saying, oh, fine, you're fine, your CT is fine. And even if you did an MRI, you may not pick up everything, because remember that a neuropsychiatric sequelae can just be something very, very mild, either in just a bit of edema and contusion, which may not show up. You can have neurofibrillary tangles with mild repetitive traumatic brain injury. You can have neuronal abnormalities which don't show up on MRI in severe traumatic brain injury. And obviously, diffuse axonal injury doesn't show up on MRIs. Having said that, the newer imaging availabilities may start to give us some yield there. But to a large extent, not everything shows up on scans. So how do you then decide which lobe or what pattern of cognitive impairment is happening? The way to look at that is to think of your cognitive function as a hierarchy. Are you awake? Are you able to attend and orient yourself? Are you able to put all your attention, orientation, visual spatial function, communication all together to make a decision? And are you aware that you don't have your memory, or you don't have your calculation, or you can't understand people properly, or that your reading is affected? Are you aware of your deficits? That's metacognition. So those are the hierarchy. And obviously, you might think it's better to be awake and attentive than to have metacognition. But very often in cognitive dysfunction, you find that somebody who has metacognition, who's aware that they get sleepy and tired and lose their attention, they do much better with cognitive rehab than people with basic dysfunction. So even though this is a hierarchy, the desirable function you want is at the top. So how do you go about the behavioral sequelae, which can have a huge impact on cognition, if not being the cause of it? Antecedent behavior consequence charting, ABC charting, is a good way to start. And here's an example of somebody who you're able to establish a pattern, and you know that it's happening mostly at a particular time and mostly after a particular period. So here is somebody who is, for instance, worried about their bowel and bladder function, and that triggers bad behavior. The second thing is the sleep log, and you then can work out whether the lack of sleep or insufficient sleep is the cause for the neurobehavioral sequelae. The Addenbrooke's cognitive examination is an excellent tool. It's used mainly for screening for early dementia, but I found it very useful. The main reason why I found it useful is at the end, not just the scores, but when they actually do the attention, do the fluency, do the memory and language, do the visual spatial stuff, you can actually then not only get an idea of which subunit of cognition is affected, basic cognition is affected. You can also, as they do the test, work out what the problem is. Now, I had a very interesting case just yesterday where the person got poor scores in all the subscores except language. But the reason for getting poor subscores was because he couldn't understand what I was telling him. So he was not doing the test properly. So even though he got full marks on language, the actual primary problem was that he was not able to understand everything I was telling him. So you can see how if you go by a score, you might think, oh, the language is not a problem, everything else is. But no, it's when you're doing the test, you realize that the primary difficulty for the low score is that he can't understand what you're saying. And then you realize that that is the key, even though the language subscore is good. So don't go by the scores, go by how they do the test. If they can't speak, so expressive dysphasia, I told you, is a huge problem in most of the acquired brain injuries. And so, and as I just told you, not being able to speak will impair your testing. The Oxford Cognitive Screen is a good alternative, which gets around the difficulty with the communication and still allows you to test cognition. It's a screening, again, test, but it will help you. And if you watch them as they do it, rather than look for the score again, it's very helpful. And there's a link there. It's both these resources. So the reason why I've chosen these particular set of tests over the last 2 decades to do this work is, number one, it doesn't have a license. Number two, anybody in the group can be trained to use it. It's not restricted to only one specialty using it. So it's a transdisciplinary test, and it doesn't have issues with licensing. You need a free license, but it doesn't have issues with that. The next one is for the next level is the next level obviously is the executive function. And here, once you've done, and usually in an inpatient setting, you'll find you need to use this sort of multiple errands test towards the end, just before they've sorted out all their basic cognitive difficulties. They're about to get discharged. You want to know whether they can go to work, go back to work. And then the OXMET or the multiple errands test becomes helpful, which is basically a task that you ask somebody to do, a set of tasks that you ask somebody to do and observe how they do it. Again, it's more than the scoring, it's the way they do it that helps. There are some practice standards available, and I'm not going to go into great detail about that because it's sort of essentially what I just have described here. But if you want to set yourself up against a standard, the ACRM standards are a good one, a good list to go for, because it's realistic. It helps you to do something in real life. It's not a theoretical model or a theoretical list of standards. The only thing I'd emphasize in all this is functional communication and functional cognition. So a person may not be able to, a classical example was a patient I saw many, many years ago who could not understand numbers. And her job was to manage a big database for a company and to order items for the whole region, for the big superstores in all the regions, so that they never ran out. And this lady could not, after a brain injury, she could not understand if somebody spoke a number to her. Reading the number was fine, typing was fine, everything else was okay. So if you go with pure cognitive assessment, you straight away say she can't do her job because it involves numbers. But what she did was she said, I just want an office without a phone. And everybody emails stuff to me. And you wouldn't believe it, I was seeing her 2 or 3 years after that. She was offered promotion several times. She turned it down only because the promotion involved going to moving to an office with a phone. And for that reason, she turned it down. But otherwise, she was doing her job fantastically. So functional cognitive assessments should override every other other consideration when you're making decisions for cognitive rehabilitation. And then you look at field deficits. And again, this is something you already know, but it's a quick test that you need to do, because very often the main thing you're looking for, which might confuse you or get in your way, is homonymous hemianopia. So quick, one finger, second finger, and both will give you an answer for picking up either a homonymous pattern or neglect. So if I couldn't see that bit, I would see this but not see this. If I could see both sides but was neglecting that side, when you did that, I would say that you were only moving this. So it's an easy, quick way to test for neglect. The other thing to remember is that the visual pathways are now being understood in greater detail, and you may or may not have read about the dorsal and ventral stream, but if you haven't, please do read it up, because it's really important. And it's also important not just because the dorsal stream helps you to answer the question where. So, this person has a cricket ball approaching their head, and the dorsal stream is telling them oh, something's moving at high speed towards me. The ventral stream is telling them it's a spherical red object and identifying it as a cricket ball. So that's how our dorsal and ventral stream function happens. And this is important when you're trying to understand cognitive visual dysfunction. There's also another thing to be aware of, and that is big objects are seen usually in one pathway. Small objects are seen in another pathway. So not every difficulty with reading is because of your refraction. It could be an actual cognitive problem. So don't be surprised when they come back with a normal eye test, but still can't see small print. And cognitive visual dysfunction, I use a little questionnaire to help me. This was designed by Professor Gordon Dutton, and he used it mainly for children, but it is applicable for adults as well. So you ask them the series of questions, and then you mark it out on a score sheet, and you'll find out whether they have patterns which are largely agnosia, largely problems with visually guided movement, largely problems with field, simultagnosia, visual attention, motion perceptions, hallucinations, and blind sight. Blind sight being not being able to see in the field that is intact. And then for each of these components, you have strategies that you can straight away use. So if somebody has difficulty recognizing people, then tell them to listen to the voice to try and recognize the person. Tell them to trace their finger around the face so that they'll be able to pick up the visuospatial information that may help them to recognize the face. Tell them to organize their room so that if they have difficulty getting around the room, organize the room and use edges, brightly colored edges. So there's lots of simple things that you can tell to help them to get around these difficulties, and label things in the house and in the office. Use if they're finding it difficult to recognize their food, and then have a plain plate with each like a thali, where each food is in a particular place, and don't change the presentation of that. And remember to again advise them about the common things for fatigue and everything else that I described, all the other things that could distract you, obviously being aware that delirium will play an important role. And then don't be surprised if some of the solutions that you have to use are more cognitive than, like somebody who had double vision. This is an example of somebody who had double vision, but they didn't have any disconjugate gaze. And the difficulty was that they had problems coordinating by bifocal interpretation. And they found that if they tilted their head, that would get solved. So that could still be a disconjugate gaze problem, where there's a particular position where the eyes then become conjugate even if you can't see it. But in this particular situation, it was actually more cognitive than an eye movement problem. And the way to find that was found out was because they were constantly tilting their head. Now, you could be tempted to think, oh, cervical dystonia, and give them botulinum toxin or something. But remember, not all head tilts are motor. In fact, there are a lot of times when not all impaired communication is language. It could be the fact that they can't recognize. So they may not be able to name the key because they don't know what it is, not because they can't find the word for it. So finally, when you have multiple problems, I talked to you about individual lobes having difficulties, but if you have multiple problems, then, for instance, somebody who has episodic dyscontrol and difficulties with reading and difficulties with language, one of the suggestions I made, which worked very well for this particular patient, was that when they couldn't understand what they read, if they copied what they were seeing, which was intact, the copying function was intact, if they copied what they were seeing in the process of writing, the understanding would reach the brain, and they would be able to understand what they were reading just by copying. And that need not be actually physically writing it down. It may be just tracing their finger over tracing their finger in the air, just copying down what they are seeing on paper, and that helped them to understand. So there are simple tasks simple suggestions that can get around complex difficulties. And again, as I said, not all voluntary control impairments are motor. You could have visual spatial difficulties, and you can see here a very nice diagram from Campbell, which talks about how the pre-motor planning area, um, will plan a activity based on what part of the cup it sees. So if it sees it like that, then it'll approach like that. If it sees it as just a handle, then you'll approach it like that. And if you see the whole cup, then you'll go to try and hold it like that. So you can see straight away that if the premotor cortex is affected, you can have difficulties with picking up a cup that are not motor, they're cognitive. And similarly, your reach, and this goes back to what I told you about the dorsal stream and the ventral stream. If your dorsal stream is not saying there's something approaching you, then you won't avoid it. You won't even bother to identify it and say, oh, this is a cricket ball approaching my eye. So not all and therefore they won't move. And that's not because they're slow to move. It's because they've been able to see the ball, but they've not been able to identify it as a ball, nor identify that it's approaching them. Right. So if somebody has dyspraxia, again, these are combinations, a combination of dyspraxia and episodic dyscontrol, then they will get very frustrated that they can't do something. They can hold their toothbrush, they can put paste on it, but they can't brush their teeth. And then they'll have an outburst because of that. So you have to be able to solve both problems, explain it to them and the families, and then not only just break up into subtasks, which is what you would do for dyspraxia, but also explain that they need to be cued, because if you don't cue them, they'll have an episodic dyscontrol and be shouting and fighting for no good reason. And as I told you about mild traumatic brain injury, finally, remember that it's a low-lying fruit, a little bit of input, telling them about fatigue, telling them about episodic dyscontrol, telling them about the lower thresholds to alcohol and any other medication, and especially pain medication. A small dose will work as well, if not too much, and they might have side effects from small doses of correctly prescribed medication because of a lowered threshold. And unfortunately, it also lowers the seizure threshold. So if you don't warn them about that and alcohol, then they might end up unnecessarily having a seizure, which then really holds their life back for the next year or two. And have a group, if you can have a community group, peer group, that will really help. We have a group called Headway in Scotland, which are very helpful in helping to just get people together, get them to talk to each other and help each other. And booklets. There's lots of available booklets. So that's a brief, as I said, whistle-stop tour of what you can do practically for cognitive rehabilitation. I would be really grateful, because I haven't been practicing rehabilitation in India for more than a decade now. So as trainees, I'd really be grateful if you can provide me feedback about what I've told you, especially from a point of view of it being appropriate or inappropriate to your real life settings. So please do send me feedback if you can. And I'm happy. I don't know whether you're taking questions or everything's okay.
We'll have a couple of questions if people have one. Yeah, thank you, Ashish. Open for discussion. Any questions? So as a PMNR trainee, this is what you need to know as a cognitive rehab. So yeah, please listen to this again. The recordings will be available. Any questions?
Ashish, I'll give you a feedback right now.
Yeah.
I think that was very, very lucid, and you did it in an unhurried way, that with a lot of content, with no hurry. I think it's excellent. Thank you very much for that.
Thank you.
Any other comments, questions? Well, I have to say a few things. Ashish has been helping us for many, many years. And he has done his presentation early morning, late at night, And we have made him wait for 30, 40 minutes because we couldn't work efficiently finishing other presentations. And he still, when I email him and ask him, can you do it? He said yes straight away. So thank you again, Ashish.
No problem. My pleasure.
Thank you.